Well, thanks so much for having me. Thanks for sticking around. My name is Alexandra Lebensohn. I'm a genetic counselor at the National Cancer Institute at NIH. It's an honor to be here. It's my second time, and it's just such a wonderful community, so I'm grateful. I'm presenting today on genetics and specifically on the BAP1 tumor predisposition syndrome. And it is kind of a weird setup. I'm realizing what everyone's talking about. Okay, so I always like to start out by reviewing some really basic concepts because genetics is really complicated and confusing. So we're just going to take it step by step. All cancer is genetic. Cancer is always caused by genetic mutations. Genetic mutations are changes in the spelling of our DNA, and that doesn't allow our bodies to work the way they're supposed to. And this is just a very, very basic visual so that you can see our bodies are made up of billions of cells. Every single cell has a nucleus, which is like the brain of the cell. Our nucleus is what contains all of our genetic information, our DNA. And our DNA is bundled up into these packages called chromosomes. If I were to stretch out those chromosomes, we would see that DNA double helix that you're probably familiar with. And our DNA is divided into little segments called genes. Our genes are basically our body's instruction manuals. So our genes are what tell our bodies how to function, what to look like, how to grow. And this is just another simplified picture of that DNA stretched out. You can see that our DNA or our genes are made up of 4 letters, A's, C's, T's, and G's. And it's any combination of those letters that make up those important genes, those important sentences, those important instructions that are telling our bodies what to do. So you can see that, a simple sentence with a single letter misspelled can change the entire meaning of that sentence and therefore the entire instruction. So changes, in our DNA change the way genes can work. So again, all cancer is caused by mutations. It's always genetic. There are 2 different ways we can get mutations. So let's start with the first type, acquired. These are genetic changes that happen during our lifetime, meaning that we acquire the mutation and our body is then susceptible to cancer because of it. So acquired mutations can occur due to environmental factors like asbestos, excess exposure to radiation, and other things. We're all living on planet Earth and all exposed to harmful things. So acquired mutations are found in our tumors. Somatic testing, or you may have heard of tumor testing, or many of you may have had Foundation 1 testing. That's a type of somatic testing. For example, that's the type of testing that looks for mutations in the tumor that have occurred sporadically, so during a person's lifetime. Somatic or tumor testing is performed on the tumor tissue itself. So that's removed at the time of surgery or biopsy. And tumor testing specifically is used to understand mutations that are present in the tumor and that can help with treatment decisions. You've heard a lot about that today. So you can learn about what drugs are best to target what pathways based on what we see in that tumor. And sometimes it can give us prognostic information about how aggressive a tumor may behave or how not aggressive it could be. And most cancers fall into this category of sporadic. So 90 to 95% of cancers just happen, and they're caused by somatic mutations that happen during our lifetime. Inherited mutations are different. These are genetic mutations that can be inherited from a parent, and our bodies are born with them, and that therefore are born with a predisposition or an increased risk for cancer. Clues that we might find inherited mutations or what a genetic counselor might look for are early ages of onset, multiple primary cancers in the same person, multiple affected generations. So when we're looking for mutations that might be running in a family, we perform something called germline genetic testing. So that's the test that we do on blood or saliva because that's representative of every cell of the body. So not the tumor, but germline testing is on blood or saliva. So inherited germline mutations may cause an increased risk for many different cancers. Only a minority only a minority of cases, so 5 to 10% of cases of cancer in general are caused by inherited mutations. Somatic or acquired mutations are only found in the tumor again, so they cannot be inherited by a future child. Germline or inherited mutations are found in every single cell of the body, and so that includes our reproductive cells like our sperm, the egg, and so that's why these can be passed on to children. This is kind of a busy slide. It shows something we call the two-hit hypothesis, which is, in a very, very simplified way, the difference. It shows the difference between sporadic cancers and inherited cancers. So in most cases of cancer, we start out with 2 working copies of every single gene, one from mom and one from dad. And over time, the longer we live, the higher the chances that we may get mutations in a copy of that gene. But we still have a backup copy. And so the problem occurs when a second mutation, at some point down the line, occurs in the same exact cell, damaging the only working copy that's left. And so that may develop into a tumor in that particular cell. A person with an inherited cancer from one parent is born with only one working copy of that gene in every single cell of the body. So there's no backup. And so as you can imagine, it only takes one mutation to that particular gene in any given cell for a tumor to develop. And that's really why we see in sporadic cancers, we tend to see that happening at later ages. The longer we live, the more mutations we accumulate. And in the case of inherited cancers, we do see early onset disease. We see people getting more than one cancer during their life, and that's just because they have less protective genes in place. Okay, so switching gears now, why are we talking about genetics at a mesothelioma conference? This is a figure that's just adapted from a study done in 2019 with NCI and University of Chicago. But this particular figure just shows a patient cohort from the National Cancer Institute. So it was 239 patients with mesothelioma that underwent germline testing by panel. And they were trying to understand whether there was a hereditary component to mesothelioma. And what they found is that 12% of that cohort actually did harbor a germline mutation in an important gene that had implications. Of that 12%, 7% actually had a mutation in a particular gene called BAP1. So the BAP1 tumor predisposition. BAP1 is a tumor suppressor gene. So that means that it's a really, really important gene. It's protecting us throughout our whole lives. It's working to suppress tumors from forming. We want it to be working because it's protecting us against cancer. So mutations or changes in this gene are actually what cause a predisposition syndrome. Mutations in BAP1 cause many different types of cancer, and they happen at earlier ages than we would see in the general population, usually about 20 years earlier. The main cancers seen in this syndrome, so if I were to see a family with BAP1 tumor predisposition syndrome, these are the types of cancers I would tend to see. The main ones are on this slide, and unfortunately, most of the cancers associated with BAP1 tumor predisposition syndrome are less common, so not typically routinely screened for unless we know about BAP1 carrier status. So sometimes cancers can be detected at late stages if we don't know about this. The lifetime risks for each individual cancer generally range from 10 to 30%, but the cumulative risk for cancer during a lifetime is high. The main cancer that we see in the syndrome is malignant mesothelioma, and about 50% have pleural and about 50% have peritoneal, which is different, right, from the general population where we usually see more lung involvement. The other cancers that we see are uveal melanoma, so cancer of the eye, cutaneous melanoma, and other skin cancers like basal cell carcinomas, kidney cancers, meningiomas, which tend to be more aggressive or malignant, and we're starting to see a higher signal for bladder cancer as well. Cholangiocarcinoma, breast cancer, and hepatocellular carcinoma are other cancers we're looking at in their association with BAP1. There are some benign features as well in this syndrome. So BIMs, or BAP1 inactivated melanocytic tumors, which have also been called BAPomas or M-Bates or even atypical Spitz tumors a while ago, they're highly indicative of BAP1 carrier status as well. They're sort of dome-shaped, raised papules that can be either flesh-colored or reddish-brown. Don't really cause problems. I mean, no sensitivity to temperature or touch. They don't itch. They're very sort of subtle. But, this study in 2017 showed that about 75% of BAP1 germline carriers who underwent a total body skin exam had at least one of these BIMs. So if a dermatologist knows what to look for, this seems to be very common in BAP1 carriers. And of dermatology patients found to have a BIM on clinical exam, 51% were found to carry a germline mutation in this gene. So dermatologists are now more frequently using this as a heads up. They can perform IHC testing on biopsies of these skin findings and see if there's loss of BAP1, and that prompts a genetic test referral. Our group at NCI very, very recently found that the BAP1 tumor predisposition syndrome is also associated with a high rate of nail abnormalities. This was very recently published. We did a prospective analysis of 40 BAP1 carriers that happened to be coming in through NCI for their annual surveillance during the months of October 2023 and March 2024. And we did extensive exams, medical photography, and nail biopsy in a subset of patients. And we learned that most of our BAP1 patients had similar unique findings on their nails, actually. They were presenting with something called onychopapilloma, and that was predominantly in conjunction with something called longitudinal leukonychia. And this was typically seen on multiple fingernails and toenails. So to back up for 1 second, onychopapilloma is a benign tumor of the nail matrix. It's underneath the nail. There's often what we call a hyperkeratotic spicule sticking out. So a lot of patients complain that it gets caught in things, and that's kind of how they realize they have this annoying thing. And it can look like a toothpick kind of running along underneath the nail. Leukonychia is just a term for white nails. So longitudinal leukonychia is specifically when there's a vertical white line running down the nail. And we can predominantly see the leukonychia, the white vertical lines over the onychopapilloma, but it does also present with erythronychia, which is a red line, splinter hemorrhage, nail splitting, or even hyperkeratosis, so just like a buildup underneath the nail. And to the best of our knowledge, this doesn't seem to be associated with much else. There are 3 other genetic syndromes in the literature where we can see this, Haley-Haley disease, Darrier disease, and tuberous sclerosis, 2 of which are very severe skin disorders. And in all of these, it's usually a single nail or the thumb that's involved. So this is, along with other significant differences, this seems to be quite unique. Given the rarity of the onychopapilloma on multiple nails in the general population, this might be a very unique finding to BAP1 tumor predisposition syndrome. Our study demonstrated that these onychopapillomas occurred in about 88% of adult carriers ages 30 and above. So not everybody, but it's, and we're still looking. This is very new, but it seems to be a good indicator right now. And these benign and sometimes very apparent nail changes seem to occur decades again before the average age of cancer onset, so it might be another very important identifying feature. And actually, let me just back up to show you. The top figure shows sort of the typical way that it can be seen on multiple fingernails versus a single thumb or digit, just the white lines. And the bottom left, you can see onychopapilloma when you see the finger presenting this way. And you can see it in conjunction with erythronychia and splinter hemorrhage. And on the other side, you can see that it also can present quite subtly, but you do see white vertical lines and little onychopapillomas under the nail. So this syndrome is inherited in an autosomal dominant fashion, meaning there's a 50% risk for first-degree relatives to inherit the familial mutation. So first-degree relatives are children, siblings, and parents. When this occurs, there's an increased risk for multiple cancers during the lifetime. And within the families, there's something called variable expressivity. So different family members can get different, within the same family can get different types of cancer. And I just want to say that it's important to realize that this information has a big impact. It carries a big psychological impact, right? Many BAP1 carriers experience a lot of guilt associated with passing on a hereditary risk to their children. I always remind my patients this is something completely out of our control. The same way that we pass on a familial mutation, we pass on all of our amazing traits to our children as well. I also heard the term survivor guilt when talking about cancer in general, and that's something that occurs in the BAP1 population as well. It's a common feeling when family members do not inherit a familial mutation because it's very difficult for them to watch family members going through these struggles and just know that they did not inherit that. But again, I remind my patients that we have no control and that, your family members benefit so much from the support that, that unaffected family member can give them. In addition, I should also just mention that it's the other thing that patients carry around with them is this responsibility to inform family members. And I can't stress enough how important that is. Sometimes we get caught up in the moment and it becomes a very sort of nuclear family issue, but this information can be life-saving. So we just always encourage our families to share with, cousins and extended relatives. And it's just so important. I know not everyone wants to know and not everyone wants to hear it right away, but I just encourage our families to share the information. There is reproductive technology available today for patients that have cancer predisposition syndromes in general, and BAP1 is included in that. So pre-implantation genetic diagnosis in conjunction with IVF can be used to test embryos for familial mutations. So during the process of IVF, embryos are biopsied and very specific genetic testing can be performed. And then only the embryos that do not contain the familial mutation are actually implanted back, or I should say transferred back for potential implantation and potential pregnancy. So that's a way to avoid transmission into the next generation. So when to seek germline genetic testing? I actually encourage every patient with mesothelioma to consider genetic evaluation. It's also very important that when you have genetic testing that you do it in the setting of a genetic consultation with a healthcare provider that's trained in genetics versus just having blood drawn as an afterthought or being tossed a kit and spitting in a tube without being consented. It's really, really important that you receive the information about the risks, benefits, limitations of genetic testing, and that you give informed consent. This information will impact you, will impact your family, and so it's so important that you understand what the testing is about, what the information will give you, what information it will give you, and also just to have the opportunity to ask questions. BAP1 mutations are more likely to be found in patients who develop early onset meso and or have more than one BAP1 associated tumor. The highest risk exists in mesothelioma patients with a family history of mesothelioma and or uveal melanoma or kidney cancer. And benign indicators of BAP1 tumor predisposition syndrome include these BIMS and polydactylous onychopapilloma, so the nail changes on multiple fingers. Those are things that should prompt genetic evaluation to find out more about personal and family history. How can genetic testing make a difference? It can provide important prognostic information, and it can allow providers to consider a specific treatment or management plan. It can alert patients to a higher risk for other cancers and allow for proactive screening. Proactive screening then leads to early detection when treatments are most effective. And it can allow family members the chance to undergo genetic testing and understand whether they may need extra cancer surveillance or not. Finally, it may also allow family members the opportunity to use reproductive technologies like PGD to prevent transmission. at NCI, the National Cancer Institute, we do have a study that focuses on BAP1 tumor predisposition syndrome. We're aiming to better understand the syndrome by following BAP1 carriers long-term with a comprehensive screening protocol. Eventually, we'd like to make formal screening guidelines. And at this time, our goal is early detection for better outcomes, but we're also hoping to keep advancing in the direction of targeted therapies for BAP1. This is the name of our study and the clinical trials identifier. Our protocol includes yearly full-body derm exam, yearly full ophthalmology exam. Every other year, starting at age 18, we do MRI of the brain. Every other year at age 30, we do MRI of the chest, abdomen, and pelvis. And every other year, we're doing bladder cystoscopy screening. All participants meet with our medical oncology team annually. And at that point, they receive health assessment. We discuss the screening results from that week. Patients provide their personal and family history updates. They obtain updates on BAP1 related information. And we discuss and facilitate cascade testing in the family. Currently we have about 220 patients. I've seen some familiar faces here. And patients travel into Bethesda, Maryland once a year to receive the care that they need by providers that know and understand BAP1. Coordinating that much screening, you can imagine, is a tremendous burden. And so we're able to consolidate the screening into about 4 days a year, which makes a big difference. And my patients talk about scanxiety. That's a real thing. And so I hope that, this study is one way to mitigate that by really making that happen 1 week a year instead of, every week of a year. I really emphasize that I want my patients to live their life using this knowledge as a tool and not letting it control their lives. So with that, I will, if I can. And before I acknowledge my team, I just want to say for our listeners out there that carry a BAP1 pathogenic variant, know that you're not alone. You're part of a really amazing community. I've had the pleasure to meet many of you. And so just know that there's a lot of people here and around the world that are working on this, understanding this syndrome better. And again, really important to live life knowing that you're using this knowledge as a tool, okay? For everyone else, please, feel free to contact me if you have questions about genetic testing or the study. I think that's really important for everyone to talk to their healthcare providers about. Thank you.
Thank you.